in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio, and I'm Buck Joffrey with my colleague and friend here, Ellen Viglione, on our mission to get through all of the pillars of what we call longevity and health. Ellen, welcome back, buddy.
Thanks for having me back,
It's always
bud.
great to have you.
Oh, yeah.
Well, we always hang out anyway, and so this is a good way to knock out these shows. But today, we're going to talk about yet another one of these, what we call pillars of longevity. And we've gone through now what we've had. Diet and nutrition was the first one, then exercise, and then we did sleep, which was really fun, I think, and probably interesting to people. And then this next one, I think we're going to talk about today, and these are not in any specific order, but we'll call it number 4, is drugs and supplements.
Yeah.
This is a big category.
Oh, yeah.
This is a multi-billion-dollar category, in fact, right? And before we get started on this matter, I think it's important to delineate between, when we're talking about drugs and supplements, we have to talk about the word geroprotective. What does that mean? Geroprotective is a word that ultimately means life extending, right? But it's kind of got a gray zone here because a number of things we're going to talk about today relate to things that can pick off and prevent some of the main causes of death. So are those geroprotective, or are those are those just things that keep you from getting disease? I don't know. I think it's a gray line, and maybe it doesn't matter. But I think the first thing that I want to talk a little bit about, and a lot about, is cardiovascular disease, and how and when we get into that, you'll kind of get what I'm talking about. But what is cardiovascular disease? I mean, not everybody knows. What does that mean? You hear it all the time.
Well, yeah. I mean, break it down. It's disease of the plumbing, and so the cardiovascular system. So it's more than just the heart. It's the blood vessels, and we blood vessels can mean the arteries, the veins, and whatnot. But generally, we talk about the heart and the arterial system. So, to piggyback off that point real quick, how do you determine whether a medication is geroprotective or life extension by virtue of preventing a pickoff of a high morbidity state?
Right.
And the geroprotective elements of what you're getting at right now, these are the medicines that are essentially designed to knock down the world's biggest killer.
Yeah. Well, you would think that. I mean, you can say that, but I think when we'll talk a little bit later, we have some medications that we don't exactly know what the mechanism is for life extension. But I want to stick with cardiovascular disease first. So you're talking about, again, the world's number 1 killer. We're talking about heart disease, heart attacks in layman's terms, stroke, etc.
Oh, yeah.
Okay, so here's what I'm going to say, and I want you to respond to this statement. Right now, cardiovascular disease is the number 1 cause of death in the world. But we have the means to make it a rare cause of death.
Yeah.
Do you agree or disagree?
It's a powerful statement. And I would say 5 years ago, 10 years ago, even early in my training, I would disagree.
Right.
Yeah, but now, absolutely. We now know cardiovascular, we know plaque physiology, we know cholesterol physiology so well now that we can get at the fundamental mechanisms of production and eliminate it.
And you called it plumbing, and I think that's, it's fair. It's very fair, because ultimately what we're talking about is the blood vessels that lead to the heart, that are part of the heart, and that's supplying blood supplies to the heart or to the brain.
Yeah.
And what atherosclerosis ultimately is this concept of deposition of plaque and narrowing of those blood vessels.
Yeah.
And so there is various conditions that lead to this. You want to talk about sort of what are the main causes of plaque deposition, what we would call cardiovascular disease?
Yeah, well, cholesterol is one. Cholesterol is a primary component of plaque deposition. And what happens is we have good cholesterols and bad cholesterols, and so there's some controversy there. But there are cholesterols that are, and specifically lipoproteins, LDL is one that's very common, that are particularly atherogenic.
What does that mean? Atherogenic.
I knew you were going to say that. It means it's got a high propensity.
I know what it means, but we're doing a show here. Come on.
Yeah, to get into the lining of the blood vessels, the endothelium, create inflammation, and create a sticky plaque. And it creates luminal narrowing. So it, like imagine, again, I use the term plumbing. Imagine a pipe that starts to pull inward.
Right.
And now, unfortunately, it's a little more complex than that. But what we're talking about is plaque development.
Some people are born genetically programmed to have a bigger problem with this than others.
Yeah, unfortunately. Very
so talk a little bit about that.
Yeah, familial hyperlipidemia, familiar hypertriglyceridemia, right? So these are patients that you can have a mutation in certain apolipoprotein B100 is one of them, whatever, it doesn't really matter. Another one is a PCSK9. If you have a mutation in that, you're more likely to have high cholesterol and atherogenic
But even if
cholesterol.
you don't have these mutations, I mean, honestly, there's a level of variability. I mean, we looked at, I mean, if you're willing to get into it, between, even you and me, both of us have, I'll tell you that I started looking into this, this whole, my own concerns about my own cardiovascular health when I was about 40, and my second daughter was just born. Who's sitting right? No, the little one's sitting over there. But my second daughter was just born, and I love you too, honey. But my second daughter was just born, and I was kind of overweight, and one day, I don't know why, but I just felt like I was having chest pain, and every one of my mom's brothers, like 3 of them, had heart attacks, myocardial infarction in their 60s. And so I was like, oh man, maybe there's a problem here. So I've been sort of following it since then. As it turns out, my cholesterol and all my lipids were not terrible to begin with, but I started getting really aggressive about treating them early on.
Smart man.
So similarly, you're kind of in the same boat, right?
Yeah. Oh yeah. I mean, it might be interesting to go through some of our stuff at another time, and we can get into the nitty gritty. Yeah.
But you work out a lot. You're in great shape. I mean, you
sleep well too.
You sleep well. I sleep well. Maybe not deep sleep, but but some of these things are like pre-programmed in us, like like time bombs.
Yeah, they really are.
Like you hear about like the guy the guy who's jogs all the time, who's lifting weights, is all ripped, and then dies of a heart attack. I mean, unfortunately, there's programming involved here that is unfortunate.
Agreed.
But here is the thing. My take on modern medicine, and you're in it, I'm not in it, is I wonder why we have not pivoted to becoming more aggressive on some of these things that we know that downstream, down the line, are going to create major problems. So, how do we normally treat cardiovascular disease right now? I mean, internists. I'm not talking about you, Dr. Viglione, but I'm talking about how are you taught? How are you taught on this?
Yeah, so phase 1 is lifestyle measures, right? So doctors will spend 5 minutes with a patient, maybe talk about diet, exercise, nutrition, right? Fundamentally. But then you get into the medicine category, and we calculate a risk score, a 10-year probability of having an event, a cardiovascular event, and then determine who needs to be on prescription medications, right? So fundamentally, I think that's very controversial, but modern medicine creates a risk algorithm for patients, and if they're considered high risk of an immediate event, but this is the problem with modern medicine, is that we're not thinking 10, 20, 30, 40, 50, right? Yeah. If someone tells you, Buck, that you're on a trajectory right now to have a heart attack when you're 65, you're not going to have a Framingham risk score, 10-year risk score, that's sufficient to say, hey, I got to be on my statin.
Yeah.
But if somebody said you're at a trajectory to do that, I'd probably jump on it now.
Yeah,
in modern
and that's
medicine.
what doesn't make any sense to me.
Totally agree with
Like,
you.
these drugs that we have are not exactly particularly toxic things, right?
There's a lot of media
So
misconception.
why are we not more aggressive?
Yeah.
Makes me downright a little bit crazy, like the way that we continue to deal with cardiovascular disease. I mean, I have, I have a friend I've referenced before, who I worry about a little bit. Who's
Not me, is it?
No, not you, not you. But he's got high lipids and stuff like that, and there's always this like. Actually, I have two friends like this, and their doctors are like, yeah, you could probably on a statin, maybe you ought to do something about it. These numbers are okay. Maybe they're not going to make them die of cardiovascular disease tomorrow, but they're almost certainly going to put them at a higher risk 10 years from now. Much higher risk than they would be if they,
without doubt,
if they didn't do some intervention to try to do it. So then why are we doing that from your perspective?
Yeah, I mean, I think there's a lot of fear in medications. I think as a society, we almost feel like medications indicate failure. I don't want to be on this. And I get patients that negotiate with me. Can I try this? Can I do that? What if I lose 5 pounds? What if I switch to a plant-based diet?
Well, that's okay too, but the funny thing is those same patients will come and be on 20 different supplements because they don't think the supplements count as medications.
Yes, I know.
It's nonsense, right? Anything that alters your body is basically the same.
Without doubt.
Okay, so I want to get into the nitty-gritty of this. Let's talk about you went to a conference recently. I know you were not super super happy with what you found, but let's talk about what's the consensus on, when or how to treat for cholesterol, what to treat with, the consensus versus what you think,
what we think,
right, or what we think really.
Well, generally the consensus is you have to create a snapshot of a patient's risk. And a good doctor will ask about their family history, their lifestyle, their workouts, their sleep, right? All that kind of stuff. You get a snapshot of risk. You can put in the Framingham risk score if you like, right? But
you keep saying that, Framingham score. So stop saying that unless you want to tell us what it is.
Yeah, so this is what it is, really. I mean, it's a consortium of data to identify risk factors that portend a 10-year risk of an event. And the risk factors are age. So age puts you at a higher risk. If you're a higher age, you're a higher risk. This is actually interesting. HDL cholesterol and total cholesterol are on this risk algorithm. Why not LDL cholesterol? I actually never got a good answer for that. It'd be worth looking into. But HDL, total cholesterol, blood pressure, smoking status, and diabetes, yes or no.
Okay.
So if you have yes, diabetic, I'm a smoker, boom, your risk score says you have a 10-year risk of 20% or whatnot. And classically, anything over 7.5%, Western medicine says you should be considered for a statin. That's what it means, essentially. Prescription pharmaceuticals. If it's less than 7.5%, then most doctors will say, well, focus on lifestyle measures or consider.
But I mean, can you look at those numbers, just pure data, and say somebody has, high LDL, it's higher than we want it to be, we should just treat them? Yeah,
and actually there are hard lines. So an LDL over 170, regardless of what your Framingham risk score, most doctors will treat.
And that's really high, though.
Well, that's what I'm talking about. I mean, you're buzzing around. Like, I think modern medicine is just sort of missing the boat in that this plumbing analogy happens slowly over time. If you don't jump on it soon enough, you're going to be behind the curve. And, maybe we'll talk about this, but it's really hard to reverse disease. It's a lot easier to prevent disease.
Right.
And that's why we're even having this conversation.
Yeah, exactly. And that's where I want to get at. Because this, to me, and this is why I want to start out with it, is, again, my statement, and I think I agree with it, that cardiovascular disease should be, given where we are now with medications, treatments, should be a rare cause of death.
Yeah, I do agree.
So we can get into my stuff if you want, like in terms of like what I'm doing.
Yeah.
Because I'm very open about, this. I didn't have an underlying cardiovascular problem. the thing that I was really worried about was, family history on my mom's side.
Mm-hmm.
And so I wanted to be aggressive about this. Mm-hmm. So I was on a statin for a bunch of years and felt like I was maybe not tolerating it great. Little, brain fog, stuff like that. That happens. Mm-hmm. And then ultimately we ended up moving to the next option, which actually ended up being a really good option. And it's what's called a PCSK9 inhibitor. Do you want to talk about what that is and the importance of that?
Yeah. So this is sort of a revolutionary class of medicines. Right. What does it do? So it directly inhibits LDL receptors in the liver. So what happens is, if you're going to knock down LDL receptors, then you're going to actually have higher LDL in your bloodstream, right? So if you have a PCSK9 inhibitor, I think it's PCSK9, right? Or is it
PCSK9?
I always kind of get this sort of.
Is it PCSK9? I don't know. You're the practicing
doctor. You say
doctor.
it so many times, you stop and think about it.
PCSK9, but
the beauty of it is that PCSK9 is not a good thing.
Like Repatha.
Yeah, Repatha knocks out the PCSK9. And PCSK9 inhibits LDL. So what does this do? The downstream effect is that it can lower LDL cholesterol quite dramatically in your bloodstream. Mm-hmm. And actually, there are genetic syndromes. These are patients that are very good candidates for it. They have mutations in the PCSK9 itself that make them particularly troublesome, where these are patients that are 20, 30 years old, walking around with LDL cholesterols of 200 or more. Right? So it's a remarkable medicine. It can drop your LDL cholesterol the most. Right. It can increase your HDL cholesterol as well, lower your triglycerides, really kind of balance your risk score quite dramatically, and reverse disease.
Well, and we saw the effects.
Yeah.
And again, I was never that bad.
Yep.
But we did what's called a cardio IQ.
Big fan.
Tell me what a cardio IQ. Tell us what.
The Cleveland Heart Labs. I mean, so nowadays we're moving away from just a classic lipid panel, which is just a little bit archaic because it looks like 3 variables. But now we're really subfractionating our lipoproteins. Yeah. And we know that there are actually better indices of cardiac risk than just a classic LDL. Good cholesterol, bad cholesterol.
So what we found from that was that I was essentially a cardiovascular Hercules.
Right. No, I was impressed.
You were impressed. I know you said that was the best you ever seen.
It really was. I mean, I know
thank you.
You're
I'm going to bring that out. I'm going to show that to, if I go on a date or something.
Oh, I dropped my cardio IQ.
Look at my cardio IQ. Something like
sorry.
That. Right. But I think it's certainly I exercise and this, that, and the other thing. But there's no doubt that was a nuclear option that it was huge, and I think my LDLs are in the 50s. Yeah. By the way, there is apparently, and I couldn't find a direct study, but there is a point your LDL gets so low that you are not only preventing further atherosclerotic disease, but you're reversing it. Yeah. And do you have a sense of what that number is?
I know. I can tell you what I've heard. I mean, so 20 to 30.
20 to 30.
Reversal.
So is there any... Okay, so maybe you don't know this, maybe no one knows this, but is there a downside to going too low?
Yeah, actually there are studies on that, really. So LDL cholesterol and cholesterol in general, lipoproteins in general, are involved in many normal processes in the body. They're not necessarily bad. I mean, our hormone milieu, testosterone is essentially a breakdown of cholesterol synthesis. The cell membranes are cholesterol-based, right? So you can't have zero. But the question beckons is how low before you cause side effects. And I'm reading things that go down as low as 10 or more. So you can suppress it quite dramatically.
The side effects of medications or the side effects of low LDL?
Just low LDL,
what?
Well, brain fog would be one of them. Think about neurotransmission. Think about synapses. Think about literally the myelin sheath.
Because they need those kinds of.
Yeah, correct.
Well, that's interesting. So So presumably there is a point. Maybe what makes sense is to even if you're diving down to the 20s and 30s. For a period of time for reversal, that ultimately you come back up to the 50s or something like that.
Well, the new thinking that cardiologists throw around is the lowest tolerable. So if you're down in the 20s, I remember calling one of my trusted cardiologists. Hey, I got a patient. His LDL is 22. What are your thoughts? Can we go down from like Lipitor 80 to 40? And he said, how's he look? How's he doing? Like, doing great, right?
Yeah.
Let's let it roll. So most cardiologists will say, if you're asymptomatic, you're clinically asymptomatic, you feel sharp, you're doing well, you don't have myopathy, muscle aches, liver enzymes are okay, all this kind of stuff, then you go the lowest tolerated.
So I think we can finish up with this, but I think the moral of the story here is we know that the lipid disorders and lipid levels and are really like the major component of cardiovascular disease. And we know we have the drugs to get it where we want it to be.
Yep.
If you get out way in front of it in your 40s, 30s, whatever.
Oh yeah.
I mean, you should not die of cardiovascular disease.
Correct.
You just shouldn't.
You got to identify your risk factors, and cholesterol is a major one, blood pressure is another one, metabolic function is another one, right? But these are identifiable risk factors. Like, we're not living in the dark ages now. Identify your risk factors, and if cholesterol is one of them, jump on it. So I agree with you.
I'm going to shift gears. We're going to talk a little bit now about metformin. So we've spent some time talking about the importance of blood sugar. We have identified high blood sugar and glucose, and that is the enemy. Inflammatory disease, all sorts of other problems, diabetics. So if you look at longevity people, people who are really into it, there's a few drugs that like everybody's on, and one of them is metformin. Metformin is a drug for type 2 diabetes, and there's a reason that so many people are on this, and it has to do with the 2014 study by Bannister et al., the UK Prospective Diabetes Study. You want to talk a little bit about the main findings on that?
Well, yeah. I mean, metformin had tremendous support. I mean, it took a little hit recently. I don't know if you want to talk about that, but from a geroprotective standpoint, stimulation of several different cellular repair enzymes, AMPK, mTOR inhibitors. But from a geroprotective standpoint, these are repair enzymes that can prolong life theoretically, at least they did back then, but also balancing this sort of pervasive syndrome, metabolic syndrome.
Yeah. The Bannister study itself showed really a couple of different things. The Bannister study showed first of all, what you would expect, that people who are on metformin did better than other diabetics who were not on metformin.
Yeah.
Here's the thing, though, is that the big thing that got people super excited, and this was the idea of geroprotection, where like it was something upstream happening, was the study suggested that diabetics who were taking metformin were actually outliving non-diabetics who were not taking metformin.
Yeah,
and that was an enormous, whoa, how could that be? Because as we know in medicine, I mean, it's diabetics got a tough road. You know, there's a lot of things that go on with diabetes that makes you a higher risk for just about every other disease known to man. And so this study comes along saying that. And the big problem with this study, though, was that every time somebody was on metformin and they added another drug, they knocked them out of the study.
Yeah, that's a controversial point.
So effectively what they did is they eliminated individuals who had progressive disease.
Yep.
So the data became sort of, kind of iffy.
Well, it's skewed.
Right. And then the study comes, Keys et al. This was recent. I think this is Journal of Epidemiology. They went back and controlled for a lot of the same problems. The study essentially showed that what you would think. That it helps diabetics, but no, they're not living longer than people without diabetes. That's kind of BS.
Yeah, that doesn't have a physiological foundation.
So, So that brings me to this concept, though, again, of like people kind of attaching on to things and not being fluid about what's going on in science. This is really important. We were talking about this earlier, you know, just with people who find their, you know, it's funny. It's almost like we're all kind of guilty of this, right? Like we find the person that we think is the smartest in the field.
And you hang on to them.
We just hang on to them and we say, well, what are they doing? And we do all the things they do. And what we're trying to do here is to promote sort of thinking, because I mean, this article to me, the Bannister and the Keys things, what it tells me is this: Metformin does a good job of glucose metabolism and make sure that you don't end up with high blood sugar. And that in and of itself is a geroprotective activity, right? Yeah. But it's not necessarily, I don't see any data here to suggest that metformin is better than anything else that controls blood glucose.
Yeah, a lot of those diabetic medications have very similar outcomes. And fixing the metabolic syndrome, fixing the hyperglycemia, all that kind of stuff, it makes theoretical sense. So is that better than Invokana, Jardiance, and all these other popular ones?
But that's a very good point, though, because now okay, so we've talked about this too. So how do you determine? Okay, now we're going into true geroprotection. Before we were talking about things that eliminate or mitigate the risk of the things that we know that picks us off one by one. Cardiovascular disease, diabetes, right? Yeah. But geroprotection, like something upstream controlling longevity, that's truly doing something different. There's this, I think this is a good time to talk about this ITP, because this is not something a lot of people, I think, talk about. It's the Interventions Testing Program, basically a collaboration with the National Institutes on Aging and several institutions across the United States. I don't know if it's outside the United States, but basically evaluating potential interventions, drugs mostly, that may delay or prevent age-related diseases and conditions. Now, these studies are primarily done in rodents.
Yep.
And hey, thank God for rodents, thank God for worms, because if we tried to figure out what worked in humans and not, it would take us hundreds and hundreds of years to do these studies, right?
Totally.
So this, to me, the ITP studies have to, in my opinion, be something that people think about a whole lot more than they do. And what have we found? The drugs that we know that have increased longevity in rodents include rapamycin. That's probably the number one. What's rapamycin?
Yeah, well, it's an immune modulator. We generally use it with organ transplants.
Right.
Yeah.
So rapamycin got a bad rap, right? Because everybody thinks it's like this drug just for organ rejection, and that that there's something maybe potentially dangerous about it.
Yep.
Because you're taking a drug that when people get heart transplants, so that's what they get. But in reality, it's a significant anti-inflammatory, right? Yeah. And this is, in the ITP, rapamycin is one of the drugs that has perhaps one of the most profound effects on longevity. I'm on rapamycin. I pulse it. That's not medical advice, but I do pulse it. How often are you giving it to patients?
I probably have like 5 or so patients on it. I mean, and really, I wouldn't say it's for everybody. Yeah. But if you're on board, I think it's something that you can monitor safely under physician's care.
There's one thing I think is really interesting, though, Alan, is that there's this whole world of longevity hacks out there, right? Yeah. And they're on all sorts of drugs, all sorts of supplements. The one we have the most data behind is a dirt cheap, old drug called rapamycin. Yeah. And the only thing I can conclude from that is that Rapamycin makes nobody any money.
Yeah.
That's
yeah,
why.
that's interesting.
That's why it's not talked about more in the popular longevity circles.
Yeah. It's not sexy. It's not fun.
No, and it's not profitable. It's not a multi-billion-dollar industry. Same thing with Acarbose. Acarbose, another thing that I take.
Yeah.
Yeah, I take it. You know that because you prescribed it for me.
Absolutely.
Acarbose, very harmless kind of diabetic medications. Again, I'm not a diabetic, but what does Acarbose do?
Oh, yeah. So what Acarbose does is it blocks the breakdown of polysaccharides in the intestines, and we have to have monosaccharides and disaccharides to get absorbed into our intestines. So basically, you're pooping out a large amount of your carbohydrate load, right? I mean, so it sounds filthy, right? But if you're having a high carbohydrate meal,
as my 10-year-old just walks out of the room because she was disgusted by you.
But there are people that take Acarbose after a pasta or a big meal, and essentially means you're not going to absorb it. You're not going to have the same glycemic load in response to it. There are also some theories that it actually works and can help the gut microbiome by feeding the small intestine, large intestine, small chain fatty acids, et cetera,
There's something about it that we know, like going back to this idea, okay, make sure your blood glucose is level because that's the enemy. But there's also something geroprotective about that.
Yeah.
And ironically, Acarbose, which is so simple, it's basically just some gut stuff.
Yeah.
Ends up being a positive result in the ITP. Metformin is not.
Yeah.
Metformin did not show a benefit in the ITP. Now, that doesn't mean it's not beneficial. Maybe it's dosing, whatever. But Acarbose did. Again,
yeah, I agree.
Why is that? Makes no sense to me why people wouldn't be taking Acarbose.
I agree.
And they would be taking Metformin. Okay.
Next drug is Invokana, trade name Invokana. Again, another diabetic medicine, very popular. And so what the SGL2 class does is actually prevents the reabsorption of glucose in the proximal tubule of your kidney.
Right.
So now we're not actually pooping out our sugar, now we're peeing out our sugar. But what's the common theme here is that we're not getting into our bloodstream where it's causing harm.
Right. No, but interestingly, though, again, there's some, it sounds like there may be some upstream stuff going on because it also has an indication for heart failure.
Yeah.
Why is that?
Oh, gosh. I mean, we're learning more and more. The SGLT2s, I mean, we're using them more for previously off-label stuff. I mean, this is subgroup analysis. The heart failure physiology, I'm not entirely clear of.
I don't know if anybody is.
But, I mean, cardiologists are using it now literally in patients that are non-diabetic with heart failure.
Right.
And it's proven valuable.
Right. So is it just canagliflozin or is it some of the derivatives like
Jardiance,
the
SGL2s,
pegogliflozin or something like that?
Yeah, Farxiga.
Yeah.
You're right. Those are the popular ones.
Canagliflozin had this problem, I think, like they had, apparently amputations and so.
There's a black box warning, but it actually got taken off.
Did it?
Somewhat recently, right?
Okay.
So further analysis actually took it off, but it's Yeah.
Okay.
So I actually looked into it, and but historically though, physicians still look at that and remember that and say, ugh.
Yeah.
So it's not common.
Well, amputations are, something that diabetics get, but I mean,
well, there you go.
Yeah.
Is it due to the medicine or is it due to the underlying disease process?
Yeah, exactly.
Yeah.
So let me ask you then, in your practice, like when you think about it as an internist, and I'm just looking at it as a physician longevity hack. I'd rather, as you know, I've tried metformin, and for me, it felt like cyanide poisoning, so I stopped. But I'm already in Acarbose. Why not canagliflozin? Why not, the Jardiance, which is similar to canagliflozin?
Yeah.
Why do you think that these drugs are getting no attention when in fact canagliflozin in particular had a pretty dramatic ITP benefit?
Yeah, correct me if I'm wrong. I don't think the other SGL2s were tested in it.
They were not. Canagliflozin was, but
and it's reasonable to think that the other members of that class actually serve the same function, and maybe they will be tested in the future.
Maybe they will be, but I think the question is like, if it had such a profound effect in the ITP, why are we not
Yeah.
Why, and we know that it's safe in humans. Why wouldn't we use that in lieu of metformin, which we know, in fact, did not have a positive impact in the ITP? We know that the Bannister study was flawed.
Yeah.
Or are we just behind?
I think the simple answer to that is off-label use. Insurance companies aren't covering it.
Metformin was too, though.
Yeah, and really, we're talking about peanuts and
is it more expensive?
Yeah, correct.
Skenaoflo is a lot more expensive. Okay,
Yeah.
there you go. It's a lot.
I mean, it's as simple as that. And I don't think that doctors are really familiar with the ITP studies, and I don't think doctors are necessarily thinking about the end game. I think they're thinking about glycemic control, and that's fair.
Doctors are thinking about getting through the day because they have too many patients now and just trying to survive.
They're just looking right in front of them.
Right.
But really, the take-home message from Jardiance or Invokana or anything in this class is, everything does have side effects, and you have to keep an eye on your acid-base status, ketoacidosis, this kind of stuff, liver function. And I think some doctors just don't want to take on the risk of additional work.
Yeah. Well,
but it probably goes deep.
Yeah. No, I guess that's true. The last one on here, and you may know more about this than me. The last one I want to mention that had a positive effect, which I'm not on, is 17-alpha estradiol.
Yeah.
What do you know about that?
Gosh, we're talking about sex hormones, and I'd have to revisit this trial, but really, if you're taking an estradiol in a man, this is where the controversy comes.
Apparently, there was no effect in no negative hormonal effect.
Yeah. I would say this, and yes. So the geroprotective element.
In fact, Alan, sorry to interrupt you, but the IT was found to extend lifespan in male mice, but not female mice.
I know, this is the paradox. And I remember when we both listened to this and read about it, we were both scratching our heads. So it had a sex distribution that was asymmetrical. But what I would say is these are doses. So when an ITP study kind of comes forward, you have to have you only have a limited amount of research dollars that go into it. So you have to choose a dose that you're going to use. And they generally do 3 or so doses, and then you look for an outcome. And these are my studies again, too. So before this is translating to humans and you're giving them estradiol, you want to see it in more doses, maybe physiologically relevant doses. But from a geroprotective standpoint, it was undeniable.
Right.
I mean, it was actually a very positive result.
Right.
So I would say from that perspective, I'm intrigued. I'd love to read more.
Have you seen anybody on this yet?
Never.
No. I haven't either.
No. And yeah, I mean, you remember we were talking about this when we both kind of read up on this, and it was just like a head scratcher.
Yeah.
Yeah. But really, the nice thing about scientific research is that you don't want to bring a bias into it. You want to just see what the data shows. And remember, all the ITP drugs actually do come forward with physiological relevance. These medicines actually get submitted to the committee because of a plausible mechanism. So I would say that's something that I would keep in the back burner of my mind, and I'd love to dig into more.
One of the reasons I wanted to do this show, these series on longevity talks, is because I think, I'm obviously interested in this for personal reasons, and what I find is that it's very difficult sometimes to separate the hype from what the reality is. And what I found interesting is that some of the things that have the most following, like the stuff that everybody's on, Metformin. I'm not sure exactly why they're on. Now, Metformin, I get it, because especially with the Bannister study, got people all excited. And I don't think that it's necessarily something that isn't beneficial, because it's going to help you with your glucose homeostasis. But then you have stuff like resveratrol. Resveratrol also failed the ITP.
Yeah.
Again, was it the right dose? I don't know. The studies on resveratrol and longevity are weak at best.
Yeah.
Resveratrol got famous because of the whole red wine link. So you can drink a bunch of red wine, but I think it ends up being like, and the animals that, they had the equivalent of drinking 1,000 bottles of wine a night.
Dose relevant.
It was all that stuff. And then the last thing is, in this space that a lot of people on, including me, are on an NMN supplementation. Now, NMN, talk about NMN, what it does.
Well, precursor to NAD. I mean,
Right.
you know,
NAD.
yes.
And which is
so NAD is essentially sort of the energy currency of life.
right.
And so NAD drives ATP production. So, you know, do you remember your biochemistry days and just kind of taking you back to the Krebs cycle, the citric acid cycle? And, you know, let me kind of spin that back for you. You know, we have our macronutrients that get metabolized for energy. And we have acetyl coenzyme A, which runs through the Krebs cycle, goes to the mitochondria, and then you have your mitochondrial transport chain, yada, yada, yada. You create ATP. Fundamentally, that's what NAD is, and NMN is a precursor to that.
And there's a relationship. You know, David Sinclair's done a bunch of work on this, but the role of NMN precursors and NAD in the whole sirtuin pathway, which is related to longevity. Now, here's a problem, though. Not the problem, but I mean, if we're going back to the ITP, NMN actually no effect in the in the ITP. It's not saying I'm still on it because I think there's enough anecdotal animal model studies to show that there may be some significance to it. Again, but NMN, I would just say be careful on that thing because now we're really talking about a multi-billion-dollar industry.
I know.
Yeah.
I mean, here's the challenge. I mean, you're just trying to find good data.
Right.
The things are going to come and go. You know, unless you're heavily invested in one product or another, we're just trying to find the truth. And, you know, I'm on NMN as well. And I mean, I'm just kind of seeking more information before I make a decision one way or another. And I think that's fine. But I think the take-home message from this whole talk is you can't be married to one thing or another.
Yeah. In fact, I would say this, okay, in conclusion, and you can come back and comment on this if you like, but I think the moral of the story of this show is if you want to talk about drugs, you want to talk about supplements, we have to start with the stuff that we know that we can pick off, the obvious things. And the first one starts with aggressive control of lipids.
Yep.
And you need to find a doctor who's going to take borderline high cholesterol seriously and is aggressive about controlling lipids, because that's the number one cause of death in the world. Yeah. And that's something that is imminently avoidable if you can get way ahead of it. So that to me is number one. The second thing is aggressive control of blood sugar. Now, how you do that is, you know, obviously there's diet and all that thing, all that stuff. Talked about metformin. A lot of people are on metformin fine. My own feeling right now is Acarbose and potentially canagliflozin because those actually showed benefit, geroprotective benefit. Yeah, I would say consider NMN, and is another thing. And then the last thing, I would just say that I'm not convinced enough to be on any resveratrol product. Yeah. What is your take?
Well, I love what you said about pick off the low-hanging fruit.
Right.
You know, as an internist, that's what I find. I mean, really, when I sit for physicals with patients, you're trying to find the low-hanging fruit that have large outcomes. Right. And cardiovascular disease is a modifiable disease. So pick the low-hanging fruit, knock off the things, optimize your risk factors, and then you can dabble in the pure geroprotective. Yeah. That's my take-home message. And I think that you can do that in a lot of different ways. But be malleable, be flexible, and understand that as we know more, these things will probably change.
Yeah. And there's a fine line. I don't want us to give, you know, like for a variety of reasons. This is not, we're not trying to give medical advice. We're giving opinions here. Although unlike a lot of other podcasts, we actually are physicians and talking about this. There's plenty of podcasts out there who are giving plenty of recommendations who or not, but I think this is a good place to stop. I mean, hey, Ben, producer Ben, do you have any questions on this topic at all?
Sure. I just had a physical, and I'm curious about what a standard panel is versus I guess what you would recommend.
Yeah, that's a really good question. So standard panel would be a complete blood count, electrolytes, liver and kidneys, a CMP, and that has a fasting blood glucose. Standard panel may or may not include a hemoglobin A1C, believe it or not. So younger patients below 65, if you don't have hypertension, may or may not get a hemoglobin A1C.
As a reminder, hemoglobin A1C is a good way of tracking blood sugar over time, right? Like if you take a blood sugar on any given day, it's basically, looking at one little photo of your entire day, but an A1C gives you an average over a period of time that really helps you understand like how well your blood sugar is controlled.
Well, I think that actually answered another question, because I'd always wondered how fasting blood glucose could give you a real accurate answer.
It's very archaic, my friend. A fasted blood glucose, as I know I'm wearing a monitor right now. My fasted blood glucose changes every day. So, it's not quite as set in stone. And if you're making big decisions based on one data point, you're kind of missing the ball.
That's why the A1C is important.
I agree. And a fasted insulin level, I find. If you're pre-diabetic or have metabolic problems, you'll see a rise in fasted insulin level. But yeah, this is all higher level stuff. I mean, really, when I first started as an attendant physician, I remember asking my colleagues, like, so what do you order for your yearly physical? They all do something different, and they all have different reasons for different things. Some doctors don't even do a urinalysis. It costs 5 cents to do a urinalysis. You can look at protein, you can look at ketones, you can get an idea of their diet. You can really learn stuff too. I mean, I look at protein in blood, but thyroid is another one. A lot of doctors don't do it. And if you're looking for large randomized trials to show numbers needed to treat for all these different lab tests, you're not going to really find it. So there's tremendous sort of variation in what a doctor will do for a yearly physical.
Okay, so here's another one. I do an annual physical. Is that enough? Should I be doing things more often?
Well, I would argue that annual is also.
I think annual is too long.
I agree. A lot can happen in annual. Not to mention we're tracking trends. So, quarterly may or may not be a little overkill. I kind of say Q or every 6 months, but it depends what you're doing. So if we're intervening upon cholesterol and we're intervening with a lifestyle measure, or I start a new medicine, I might want to see what's happening in 6 weeks.
Right. I mean, I think what we're advocating for too is this migration towards what we call medicine 3.0, which is very appropriate for where we are in the social media age and sort of creating your own knowledge. We have what it takes. We have the ability now to track our own data, and doctors can do a lot, but like anything else, your own information and your own health is of your own best interest more than anybody else. So if you can take control of that, then I think that's really important. So to Alan's point, for example, like when I started the PCSK9 inhibitors, and we were following that at least quarterly. I mean, maybe even more, to find out how those numbers were drifting down. You may want to do that similarly if you're trying if you started metformin, you start other kinds of things, or you start a diet and exercise. And by the way, you look better. I mean, you've been working.
He's listening to our podcast.
You've been working out?
Listen.
Yeah. But like, I bet if you're working out, I think it's reasonable to get those numbers. It's the same reason that I think people often suggest getting on your weight scale every day.
Yeah.
Right? Because it'll keep you honest. You don't miss 10 pounds and all of a sudden be like, oh, how'd that happen?
I love that.
You're on it every single day.
Yeah.
So the more, and we have an entire pillar on this topic because we're strong believers in diagnostics.
Yeah.
But I think more testing is better.
Yeah, I agree. And it's participatory. So it's patient participation. It's not the doctor ordering something once a year. With Quest Diagnostics, you can even order your own stuff now. And it's kind of revolutionized the industry. But it doesn't have to be a big deal. So the more data points you get, the more trends you get, and the more you really understand your own body.
Well, I think that's pretty good. I think we covered this latest pillar, Alan. Yeah. So let's call it a day. Thanks again for joining me, and we'll come back. Yeah. We got 2 more pillars left. We'll keep them a surprise. That's it for us. Thanks for joining.
Thanks, bud.